Good afternoon. I would like to extend an extremely warm welcome to everyone to the annual public meeting of Nottingham and Nottinghamshire Clinical Commissioning Group. Could I have the next slide, please? My name is John Towler and I chair the governing body of the CCG. Of course, it would have been great to have been able to hold this meeting face to face, and I'm sure we all hope that we may be able to do so again next year. But for now, I would like to thank everyone for taking the time to join us in this virtual setting this afternoon. In my 13 years of being involved with the NHS, I've always been passionate about how we engage with the population we serve. So annual public meetings like this are important because they allow us to share how we've performed in the last year, but also for you to have the opportunity to ask questions of us. And I'll explain a little more about how that will work, technology willing, in a second. Next slide, please, Rachel. Our agenda today will see a number of members of our governing body giving short presentations about key aspects of our work, followed by a video from Dr. Cathy McLean, who is the chair designate of the proposed new integrated care board for Nottingham and Nottinghamshire. We'll then move on to a question and answer session. So there are a couple of ways you can ask questions of us this afternoon. Firstly, throughout the meeting, you can click on the Q&A button, which you should be able to see on your menu, and type any question into that box. I will then put the questions to our panel during the Q&A session when we get to that point. Secondly, if anyone has a microphone and would like to ask a question verbally, I'll enable that function later in the meeting, and we can also use that route. However, please note that we are recording the meeting this evening, and it will be available on our website next week once we've taken the time to embed British Sign Language interpretation from the Nottinghamshire Deaf Society. So if you don't want me to use your name, please just ask questions by typing in the Q&A box where you will be anonymous. Could I have the next slide, please? So I'd now like to ask our presenters to introduce themselves, please. Amanda.
Thank you. Good evening, everyone, and thank you very much for joining us. I am the Accountable Officer for Nottingham and Nottinghamshire CCG. Hello.
Thanks, Amanda. Stephen, please.
Hello, I'm Stephen Short. I'm a GP in East Leek and I'm the Joint Clinical Leader with James. You'll hear from him in a moment.
Thanks, Sue.
Hello everyone, I'm Sue Clegg. I'm a non-executive director here tonight, and my role is as lead for patient engagement, and you'll hear me refer to our committee as PPEC. Thank you.
Thanks, Sue. Stuart?
Yeah, good evening everybody. My name is Stuart Poyner. I'm the Chief Finance Officer. Good evening.
And James.
Good evening, everybody. I'm James Hopkinson. I'm a GP in Calverton and I'm Joint Clinical Lead of the CCG, joint with Stephen.
Thanks, James. And Rosa.
Good evening. My name's Rosa Waddingham and I'm the Chief Nurse for the CCG.
So thank you, Rosa. And now I'd like to hand over to Amanda to start to lead us through our year in review.
Thank you very much, John. Next slide, please. So just a little bit about us to start with. So you can see here, we were formed actually only on the 1st of April 2020. And so for the whole life of this organisation, we have been very much focused on dealing with the coronavirus pandemic, just really literally a couple of weeks before we formally came into being, we started our response for that. We have a 1.8 billion budget, so very considerable resource for the benefit of people who live in Nottingham and Nottinghamshire. And we plan, buy and monitor services across the health service for the 1.1 million in our patch. And we have nearly 500 staff working really closely with two main acute providers, one key provider for mental health and learning disabilities, 126 GP practices, two community providers, independent and voluntary sector partners and services. And we are also part of the integrated care system. And whilst we have been commissioning NHS services for a number of years now as CCGs, we are moving into a different way of organising commissioning and provision as well, so that all parts of the health system work more closely together and more closely with our colleagues in local government as well. More of that later. Thank you. Next slide. So I have to say, I remain incredibly proud and feel really privileged to have been part of the overall COVID response. These pictures show vaccination, but in addition to that, the CCG has been the lead organisation to coordinate the NHS's response locally, working very much alongside partners, but the CCG has a coordinating role in terms of responses to emergency incidents like the pandemic. People have come together, worked incredibly professionally, incredibly flexibly. People have done remarkably different roles. People in our communities have rallied volunteers, absolutely tremendous, and that has continued right through to the present day. Thank you. Next slide. So also really proud that we have taken early steps to move some of what the CCG does out into our places, Mid-Nots, Nottingham City and South Nottinghamshire. And this is all part of the overall health and care system. So you can see here that working in those places, we have a number of really tremendous developments. So the virtual ward within Sherwood Forest Hospitals and out in the communities, over 400 people have been seen safely through that service. And that means that that keeps hospital beds free for the people who really need it and have needed that through COVID. And it's meant that we have been able to deal with everybody's needs in relation to COVID. Wellbeing clinics with the voluntary sector as well, helping people return from isolation. It can be quite nerve-wracking when you have been used to being on your own and getting back into that, but also really lonely being on your own potentially as well for some people. Social prescribers as well, linking the health services in with wider sort of things that are really important to people. People have many aspects to our lives, and we have needs other than that are probably more important in many ways than the National Health Service, and we need to connect those services together to help people deal with a range of challenges. In Nottingham City, the Rough Sleepers project has been a really remarkable example of partnership working across broader public sector, and 16 community days of action as well. So this shows a sort of that we're starting to think more broadly in terms of how we work with partners and colleagues to think about joining up those whole services for the benefits of the people that live in those areas. And then in South Nottinghamshire, community development and community engagement structures, supporting grassroots community and voluntary services to thrive and reintegrate back into communities, and a community online sharing platform as well for networking and, again, connecting people. So we see these as really, really critical building blocks of the health and care system. Thank you. Next slide. And within each place, we have a number of primary care networks, which we sort of, you might call, are at more of a neighbourhood level. And again, this is really, these are the bedrock really of the health and care system. Again, we've got GPs working collaboratively across practices, delivering boosters. We've had pop-up clinics. You can see here we've had extended access for people as well for GP appointments, and even throughout the pandemic, where we've had to, keep people as safe as possible, both staff and patients. 57% of people are seen face to face following a telephone conversation. And if you do need to be seen face to face, then you will be. We've got an additional nearly 250 people in what we call supporting roles, additional roles, to really improve the capacity out in primary and community care to support that wider work around the GP practices. And the social prescribing, the green space, we're really lucky. We have got a quarter of or £500,000 to develop that social prescribing green space. Things like exercise, walking, cycling, gardening, things that help really that wider wellbeing. TeamNet is a communication platform for our practices as well. Lots of information throughout the pandemic as well. Things have been very rapidly changing, and that's been a really important way of helping keep our response to COVID as coordinated as possible across the area. Developing our clinical leaders, next generation of clinical leaders coming through as well through the PCNs, which is great, and providing that enhanced support around care homes as well. So again, a huge variety of things that we have been doing. Thank you. Next slide. Back to John.
So thanks, Amanda. And I think particularly for talking us through those really important service developments that we've been able to make right across the city and the county, whilst at the same time responding, as you have described, to all the challenges of COVID. So thanks for that, Amanda. I'll now pass to Stuart Poyner to talk through our financial performance.
Thank you, John. Thank you, Amanda. Firstly, I think probably most speakers tonight will recognise the unique year in which we had from April 21 through to the end of March 21. And I suppose it is unique, and I just echo Amanda's tributes really to not only, I suppose, all of our staff and how they adapted and worked differently, but the whole system that pulled together. And I think it did mark the beginning of a change really in terms of the way in which the relationships have changed and improved, and it's really been quite an encouraging change, and that is probably shows in the way in which the finances have worked differently. So traditionally we'd be sitting here talking about activity-based payments, payment by results, and managing the CCG's finances through a set of traditional contract approaches. Very early on in terms of the pandemic, the normal business rules for the CCG and for the NHS generally were relaxed, and we moved into a different financial regime, which is primarily built around block payments. And in addition to the block payments and the resources that Amanda talked about, the 1.8 billion, there was also additional resources made available for the health system and for the CCG to directly meet the costs of COVID, which are over and above the spend levels that we had in the system already. So if we could go to the next slide, please. And this slide just gives us a sense of the scale and breadth of the spend within the CCG. So you can see that the main section there is spent on acute services. We've got £844 million that we spend on acute services, and just a couple of headlines around that. Just over £500 million, £555 million goes to NUH from the CCG, and £254 million goes to Sherwood Forest Hospital. So again, two really big providers in our patch, and play a key role obviously in the health system, and particularly over the last year in relation to COVID. In terms of community services, Amanda mentioned, we've got two key providers. We've got the Healthcare Trust, Nottinghamshire Healthcare Trust, That was a payment of £81 million for community services, and City Care around £50 million for City Care as another key partner. You'll see then we've got £183 million of mental health services. That's split in the main with Nottinghamshire Healthcare Trust, who's our main provider, but we also work quite extensively in the independent and private sector, which takes around £20 million. The primary care figure of 358 million, I'm obviously just giving you the top headlines for each of these sections. For primary care, we have GP services in primary care, 156 million. And a figure that's always astounds me is that the prescribing spend is 157 million. So the prescribing spend matches the overall sort of infrastructure costs of and paying for primary care as well. EMAS is pretty much our sole provider for ambulance services. So that's the £40 million. And then in terms of continuing healthcare, and again, another big area of cost to the CCG, supporting patients and service users outside of hospital. And that's one of the areas where COVID spend that shows in our books, in effect, where we spent over £30 million extra this year in supporting continuing care and supporting areas of hospital discharge. And probably just an interesting figure overall. Overall for COVID, we spent £150 million extra across the board for COVID this year in the health system. So if we could just move to the next slide. Amanda introduced saying that we've got a £1.8 million budget. It's always a relief when I'm able to put this slide up to show that we've actually spent 1.8 million. If we just spent 2 million, I probably wouldn't be here to do tonight's presentation. So that's good that we've balanced our books. We have also operated within our running costs. So organisations like the CCG are giving allowances for their running costs, which are around running the organisation and estates costs. Like any business, we have to manage cash, and we set cash targets. And then the final financial duty that we have is around paying our suppliers on time. And that was really important actually during the pandemic to make sure that things continued to work smoothly in the NHS. So I'm pleased to be able to report that we did meet our financial duties. It was a very different year with a lot of the payments that we were making being prescribed and defined nationally, but I'm still pleased to report, and I'd like to thank all of the staff in the CCG for their contribution to delivering on our financial duties. Thank you.
Thanks, Stuart. So I hope everyone has found that breakdown of how we've been spending our money useful and interesting. And certainly it is a very significant amount of money that we have spent in response to the COVID pandemic very appropriately, I think. So thanks, Stuart. I'd now like to bring in Rosa Waddingham to talk to us about our very important quality work.
Thank you, John. So much as Stuart and Amanda have said before, this has been a very different year for quality and has seen our quality work be much more hands-on out in our community. Next slide, please. Despite the challenges that we faced, we continue to see really high quality ratings for our GP practices, with 81% rated as good and 15% outstanding. And we've also seen an increase in the number of good and outstanding adult social care placements, which is impressive considering that that's a sector that's been under considerable pressure throughout the COVID pandemic. We've continued to have a focus on personalised care, and our social prescribing link workers have been really active during COVID, supporting communities to connect and supporting some of the work we'll all remember around delivery of prescriptions and support to people who are isolating at home. We've also supported over 10,000 personalised care and support plans and achieved our target of over 1,200 personal health budgets. But what's really come into acute focus in the last year is our real focus on embedding approaches to health inequalities and making this a central tenet of the work that we do. Equally, we've taken a much greater role in infection prevention, control, support and advice during COVID-19, both within our GP practices, in our care homes and across our wider system. Next slide, please. So I mentioned briefly about care homes. As I said, they've been an absolute really important part of our response to COVID and have been hit by a number of challenges over the last year in being able to respond. So we've worked closely with partners from the local authority and from the sector to focus on critical issues and support them to meet that operational demand. As part of this, we've set up an enhanced care response team, and through that offered over 6,000 training sessions around infection prevention control, safe admission and discharge, and various other topics. And we've worked with the sector to develop some additional staffing offers, working to create a social care faculty to encourage people to stay in social care and to support our patients in those settings. Next slide, please. We also recognised in the last year that we have a number of services, especially maternity, that do not provide the quality that our patients deserve. And we've been working actively to improve quality and safety in the services that are being provided today. Very much listening to people with lived experience and our Maternity Voices partnerships. And also learning from some of the maternity reports from elsewhere. So the Ockenden report was published late last year, and we've been working very carefully with our partners to make sure that all of the services within Nottingham and Nottinghamshire offer safe and effective care to women who are delivering. Next slide, please. We've also had a huge amount of work being undertaken by our medicines optimisation team, and one of the biggest things they've done is support the COVID vaccination response that Amanda talked about earlier. They've really been essential to making sure that that service is run safely in line with specialist guidance, policies and procedures. But alongside that, have also continued to support the care homes and GPs in safely managing medicines. Next slide, please. I also wanted to really talk to you about our equality, diversity and inclusion work. Over the last year, we've been absolutely committed to improving the equality of access to health services and health outcomes for the diverse population that we serve. And some of that has been through our work on health inequalities and the development of a strategy around that. But in practical terms, that has been demonstrated by our approach to the vaccination programme, where we've worked with communities to provide those services in a way that meets people's needs, using a variety of community settings. We've focused our recovery work on the patients in our 20% of our most deprived neighbourhoods to try and balance out some of those health inequalities I referred to. And again, we're working through maternity to ensure that key areas where we know there's additional need have a focus for our continuity of care teams. We've also done some active research and work around improving the mental health outcomes of LGBTQ+ people in Nottingham City. Thank you, John.
Thanks, Rosa. Just before we move on to the next presenter, part of the reason we hold this meeting every year is to allow partners, members of the public and staff, colleagues to ask questions of us. So I'd just like to remind everyone that if you do wish to submit a written question, that functionality is open now. And if anyone wants to do that, just click on the Q&A button on your menu. And you should be able to type a question that we'll ask when we get to that session. So as I said at the beginning, engagement with the local population is of paramount importance So we'll now hear from Sue Clegg about the work of our Patient and Public Engagement Committee. Sue.
Thank you, John, and hello again, everybody. So I'm the chair of the Patient and Public Engagement Committee, which I'll refer to as PPEC from now on. We are an important part of the CCG's work in terms of engagement. A group of about 20 of us. I chair the committee. I have a vice chair. We have representatives from the voluntary sector for our 3 defined places. We have representatives representing our commissioning intentions in terms of health issues. We have representatives from communities with particular barriers to access of healthcare. We involve Health Watch, and we have local authority representation. And I just want to take this opportunity to thank all the members of PPEC for their hard work during this year, a number of which is done on a voluntary basis. It's very much appreciated. So we are a strategic advisory group to the governing body of Nottingham and Nottinghamshire CCG, and our role is to ensure that patient and public engagement informs the CCG's role as strategic commissioner. Over the past 12 months, we've provided advice and guidance to the CCG's approaches in various commissioning programmes, and tonight I'd like to share one example with you. Next slide, please. So this is our role in the programme of involving children and young people's mental health, early intervention and training. The purpose of this engagement was to really understand the views of children and young people, their parents and carers and professionals, to help shape the future children and young people's mental health, early intervention and training pathway. The feedback involved gathering online surveys, focus groups, telephone interviews, and the CCG's engagement team worked in partnership in an innovative way with the youth-led project MH2K to really deliver engagement for young people. Various approaches were used: email, social media, website, bulletins, YouTube videos, press releases, texting, and attending virtual groups. We had more than 400 responses, which is a very good response to engagement work. About 100 from young people themselves, about another 100 from parents and carers, and about 200 from professionals. The project started in May 2020, and the engagement took place in late 2020 autumn and just into Christmas. And the findings, firstly, and very importantly, inequity in access across the ICS. So the current services delivered through 5 providers. It was found to be a fragmented service, which led to confusion for patients and too much redirection between providers. It identified a need for greater awareness of early intervention, and also the need for immediate access with no thresholds and flexibility of support. Greater non-judgmental support for parents and carers was identified as a need, and greater communication and involvement with those carers. It also highlighted the need for more training for professionals, delivered in conjunction with the young people themselves, and unsurprisingly, better partnership working between mental health services and other organisations. In other words, a more joined up service. The Patient and Public Engagement Committee helped provide feedback and contributed to the engagement plan. We shared contacts to approach as part of the engagement, assisted in the creation of promotional materials and resources, and significantly promoted the engagement through PPEC's communities and networks, which in itself can reach thousands of people. We reviewed the progress of the recommendations as a result of the engagement and encouraged the development of a "You Said We Did" resource to provide feedback to the commissioning team and close the engagement loop. This work has helped to meaningfully capture the views of service users, parents and carers. and was used to inform commissioning plans. Commissioners have initiated, on the basis of this and other considerations, a lead provider tender exercise with a view to improving the service and achieving better outcomes for our service users. And we should see the result of that tender come through this November. Thank you.
Thanks, Sue. So I think that's a really good example of how proper listening to the population that we serve and stronger partnership working with other organisations in the NHS and local authority really does lead to better services. And I'd just like to take the opportunity to thank Sue and all members of the PPEC for their leadership in this area. I think it's been extremely important to us over the last 12 months. So since the inception of CCGs, it's always been a fundamental principle that the organisation should be clinically led. So I'll now pass over to Dr. James Hopkinson and Dr. Stephen Short to talk about how that's working in practice. James, please.
Thank you, John. Well, good evening, everybody. I just wanted to talk a little bit about elective care as it affects a very large number of our population. So following the COVID pandemic that we've been living through for the last period, one consequence has been a huge number of people are on waiting lists for planned care. So this might be people waiting for a new hip or a knee operation, and addressing this large backlog of patients is a big priority of ours. Now, this priority and problem is not unique to Nottingham. It is an issue across the whole country, but it's, however, a really significant challenge. So one of the problems is our hospitals are unable to work at full capacity still due to the restrictions of social distancing. And we've still got 200 of our beds across our system occupied by COVID positive patients. We're drawing up plans on how best to tackle this with clinicians from the acute hospitals, the mental health trust and the communities, including general practice, all working together to maximise the opportunities to work differently and to prioritise those most in need. We're also using every bit of capacity that's available to us, including the local private hospitals. But the reality is this challenge will take a significant period of time for us to get back to where we were pre-pandemic. Even if we could create more beds, it's a real challenge to staff them. Also, we're about to enter into winter, and to be able to keep our elective care happening, we need to be able to keep our beds available for operations throughout the winter. So we have a really big focus on winter planning, looking at keeping people well, keeping people out of hospital, and also getting people home from hospital as quickly as possible. If the hospitals fill up, we have to use the beds that we reserve for planned treatments and operations. So hopefully you can see how big a challenge this really is. I'm not trying to paint a negative picture or make any excuses, but I do want to be completely honest about where we're up to and the challenges that we have here in moving forwards. But I can honestly assure you that there are lots of really good people working very hard to do the best we can in these difficult times. Can I hand over to Stephen, please?
Hello again. Again, as a local clinical leader, I've done a few of these meetings over the years. And over my career, it's been as a leader in general practice, the health authority, a primary care group, a small primary care trust, a large primary care trust, a small commissioning group, and now this large commissioning group. Really, it's a dizzying environment. Big structural changes and reorganizations every few years, and now we're on the verge of becoming an integrated care system. I really do enjoy these opportunities to have direct conversations with the public and my fellow citizens. I am a Nottingham resident. I've been a Nottingham resident since 1981, and also with patients. There are many forces, I fear, which are trying to create tension between professions and the public at the present time, almost casting us as adversaries. But please be in no doubt, we do not regard patients as the problem, and yet it's entirely the opposite. Patients are our purpose. And I don't know anyone in our system, whether they be clinical, care professional, or the way too often derided but utterly essential managers, who isn't committed and working hard and trying to be better for our citizens. I'm not known for painting a falsely upbeat tone, and to paraphrase Napoleon, and I bet you hadn't thought you'd hear from him tonight, great leaders must define reality and give hope. The reality is that things are really tough, really tough indeed. The workforce is jaded, despondent, and I fear in places burnt out. Workplace conditions are hard and unsatisfactory. Demand is currently outstripping our available supply. I know at first hand as a GP that patients have been incredibly generous, reasonable and kind for more than 18 months, but now starting to feel the same as well. And yet the hope is that this policy of integration is without doubt the right one at the right time, finally. Integration, after all, is defined as bringing one or more things together to make things better. And those of us involved in your health and care are coming together explicitly to take responsibility for the whole population and its needs, and to be accountable to each other and to you for to ensure we get the very best outcome we can for the combined resources we possess. We are systematically going to look at all those areas where we can do better and problem solve it together and with you, including those areas that James has mentioned just a moment ago. A good example of the improved care of those is the improved care to those who live in care homes, where health and care, hospital community, doctors and nurses and therapists have come together with care home staff to improve the quality of care to this particularly vulnerable group to whom we owe a special duty of care. There are many other examples as well. Can I finish by paying a sincere and public tribute to our clinical, care professional, managerial and support staff, including not just those who are visible in the emergency departments and the general practices, but those less visible in care homes, voluntary services, mental health. I'm really proud to be in your team. Thank you.
Thanks, Stephen, and thank you, James. As many of you will know, and as we've alluded to a little already this evening, over the last 2 to 3 years, NHS bodies, along with local authorities and other partners, have been working in a much more joined up way to provide integrated care that should deliver a better patient experience and improved outcomes for the population. The government are now planning to enshrine some of those changes in law and have therefore appointed a chair designate for the proposed new Integrated Care Board. I think, as you can see on your screen, that chair is Dr. Cathy McLean, who is also the chair of Derby Royal Hospital. Cathy is unable to be with us tonight, but she's recorded a short video outlining some of the changes which will be taking place over the next few months. Play the video, please.
Hello, my name's Cathy McLean and I'm the chair designate of the Nottingham and Nottinghamshire Integrated Care System. I'm really sorry I can't be with you tonight. I'd have loved to have joined you live, but I'm unable to do that. So I thought I'd send you this little message. I think what you've been hearing about just in the last few minutes has been looking back over the last year, and my goodness, what a year it's been. But I'd like to look forwards and think about what we're going to be doing over the next few months and into next year. So Nottingham and Nottinghamshire has been working together, health, local authorities and a range of other partners for quite a number of years now. But at the moment there's a bill going through Parliament which, if it's successful, will turn the integration and the partnership working into something more formal, so that by April the CCG will cease to be, but it will morph into the Integrated Care Board, which will be the new body which takes on those functions. So we've got quite a lot to do over the next few months in order to get ready for that change. But much more exciting and much more important is the work that's going on at a local level across our system to change the care that's offered and improve the quality of care, reduce health inequalities, and overall make sure we're a sustainable system. So we've got 4 places, we call them, Bassetlaw, Nottingham City, South Nottinghamshire and Mid Notts. These are areas which are communities really, where the doctors, nurses, social workers, voluntary sector come together with citizens to work out how best to deliver care. And we've already seen quite a lot of improvements as a consequence of that. But these changes will allow us to accelerate that and provide the right resources and support to those areas. And we also have primary care networks or neighbourhoods, so smaller areas which are even more local where changes can take place. And we know lots of good work has already been going on. For example, much of the vaccination programme for COVID-19 has gone on at that level. So I'm very excited about the prospects of what we can achieve together working in collaboration, all of our hospitals, all of our GPs and our social care colleagues in the local authorities. I'm very optimistic that we'll be able to make a big difference to inequalities by reducing them and to the quality of care, improving outcomes, and also, really important, preventing illness over the next few years. So I will be building a team in the system over the next few months, and I'm very much looking forward to working with everybody and look forward also to speaking with you again, hopefully in person in the future. I hope you enjoy the rest of the evening, and again, apologies I can't be with you.
I'm just going to pass back to Amanda now, who's going to say a few additional words about our plans for integrated working across Nottingham and Nottinghamshire.
Thank you, John. And yes, just to follow on from that. So I would say this is part of a journey really in terms of how we all work together. And the CCG has already changed quite a lot in terms of how we work. And you've heard some of that this evening. So we now, instead of kind of just the CCG doing the plans for services over the coming year, we now do that jointly as a system. And the benefit of that is that we join up the clinical insights from GPs and also hospital teams, community teams, with the professional perspectives from social care and also in the hospitals and the way that things are work operationally, taking that into account in our planning as well. So we are thinking about how we plan our health services much differently already. We're working in our places, which we've talked about again already. And we are working jointly. So the CCG teams, again, are now working really as one team with colleagues across the system on things like how we can help prevent people needing to go into hospital if that's possible, working with 111, helping to ease the pressures on the emergency departments, and also how to discharge people in a timely way, working with our council colleagues very much in the care homes. Our pharmacists were working on the vaccination programme, particularly this year. So we are working, our teams are working as part of the wider system. We're not working as a kind of separate organisation in that way anymore, and we will continue to do that. We're particularly looking at how we can jointly plan and deliver services with the councils in children and young people with complex needs, sort of personal budgets and personalised commissioning, as we call it, continuing healthcare, and also how community services work. So we're sort of producing with citizens and other partners further sort of thinking around that. We're also putting the Integrated Care Board in place. That will be the NHS body that takes over from the CCG. It's called a board, but it's actually a body like in the Welsh and Scottish system. They have health boards. And by the end of the year, we hope to have recruited to the board for that. So that will there'll be a chief executive appointment, and then non-executives, and then the other executive roles as well. And we hope by the end of this year. And then also making sure that the leadership in places is adequately resourced and able to, take forward the good work that we've already described, and that we're linking in with the councils in terms of understanding the overall health needs, and again linking in with the health and wellbeing boards. So in practical terms, we'll be putting the new body in place for the rest of this year, aiming to sort of operate as much as we can in sort of shadow form early part of next year, assuming that the reforms go through Parliament, and then we will be ready to continue along this journey from April next year. Thank you, John.
Thanks, Amanda. And thanks to all the presenters. We've now arrived at the question and answer part of the agenda. Our presenters this evening will form the panel and will, of course, do their very best to answer your queries. Just to note, please, that we would be grateful if you could avoid person-specific issues, as we are unlikely to be able to answer those in a public session. So I mentioned the raise hand function at the beginning. I've now enabled that for attendees. So if anyone has a microphone and wants to ask a verbal question, then please use your raise hand button, and in turn, I will enable you to speak. Just to note as well, you'll still have to unmute yourselves manually using the mute unmute button. And of course, you can still submit any typed questions using that Q&A button as well. So I have some questions submitted both in advance of the meeting and via the Q&A function. So I'll work through those. So the first question that we've received reads as follows. No one can fault the work that the NHS has done and is doing to help the public, especially with COVID. But is there a way to get more lines into the surgery? Because no matter what time of day you ring, there is always a queue of patients. I rang in the morning and I was caller number 20. So I hung up and called mid-afternoon, and I was then caller number 18. One line to the surgery isn't enough, and winter is soon upon us, with GPs having more phone time. Somehow there's got to be a way of getting more lines through. Please can you try and look into getting more lines open, please? So obviously that's a question that's specific to one particular practice. But James, perhaps if you'd like to respond and broaden it out as you wish.
Yes, thank you, John. And thank you, Loretta, for the question. So I'm sorry you're finding it difficult to get through on the telephone, but I recognise this as an issue that actually it's being raised across practice throughout the country. In fact, the practice in question, Roundwood Surgery, doesn't have one line. It's recently updated their telephone system. They've actually got 30 lines. So when you find yourself 18th in the queue, it's because there are 17 other incoming lines already being used. So the demand upon telephones in general practice has massively increased as we all try and reduce the footfall into GP premises due to the COVID pandemic. And Roundwood actually gets around 600 calls per day. There are multiple people in the practice trying to answer telephones at any one time, trying to minimise the wait. So it isn't one person just answering, waiting for 18 calls when you're 18th. But the rate limiting step here isn't the physical number of telephone lines, actually. It's the number of staff who are able to answer the calls. So I hope that answers your question.
Thanks, James. Okay, the next question we have also relates to general practice and reads as follows. My question is, what are the CCG planning to do to expand the availability of space in general practice, as infrastructure funding and progress seems not to be keeping up with overflowing problems? I'm asking this because I'm responsible for placing medical students in general practice, and increasingly practices are saying that they literally have no space at all for a student to be. It seems that the arrival of PCN additional roles reimbursement scheme staff, whilst a good support, has highlighted the size of practices and the lack of infrastructure funding for building expansion. This placement problem means that the experience in general practice is suboptimal, as this often impacts upon recruitment into general practice in the future. So that question came from Christine Johnson, who's the Community Sub-Dean at the University of Nottingham. Stephen, I'm going to hand that one over to you, please.
Yes, and it's a perfectly reasonable and coming from Christine, as we'd expect, a really sensible and carefully thought through challenge to us. We are at the present time undertaking a review of our primary care strategy to explore the opportunity to develop a model of primary care designed to improve outcomes and invigorate the practice of high value primary care medicine, which clearly is predicated somewhat on having appropriate physical accommodation. And so that will form very much part of our primary care strategy review, and we'll have hopefully something to say about this as we complete that piece of work. There is the PCN ARRS staff, for those are those colleagues on the call who are unaware what this is, these are the new members of staff recruited by PCNs, primary care networks, physios, pharmacists, social prescribing link workers, paramedics, care coordinators. They're clearly all designed to improve the range and quality of services that general practice offers, and they do require some physical accommodation and proximity to feel part of the team, and that's clearly essential. Interestingly, the development of PCNs has enabled practices to more commonly share resources, share their accommodation, share their buildings, share their staff, and this is a very positive aspect of the new developments of primary care networks. But nevertheless, it's an important question for Christine. We want to make sure there's appropriate physical environments to train young doctors of the future, to create the pipeline of high quality young doctors into general practice in the future, and we'll be certainly taking account of it in the construction of our primary care strategy refresh.
Thanks, Stephen. So the next few questions all come from attendees tonight, so thanks for typing those questions as we've gone along. And the first one is, did the CCG have any insight or raise any concerns during their monitoring meetings or quality visits about maternity or the A&E department or culture of the Nottingham QMC Trust? So I'm going to come to you, Rosa, first, and then Amanda, you may want to add on.
Thanks, John. Yes, we did have some insight into some of the issues that were in the most recent CQC report that were published, but not all of them. Where we were aware of concerns, we formally wrote to the Trust to work with them on a shared action plan, and we have a number of actions plans in place already in advance of that report to address some of the issues that it raises. However, there were things that we weren't aware of that CQC found, and those things we're working with the regulators, CQC and the Trust to act on at pace to ensure that we can make services as safe and effective as possible, as quickly as possible.
Amanda, did you want to add anything?
Yes, thank you. I mean, I did mention at the beginning that part of the role of the CCG is around monitoring of local services, and we do work alongside the regulators as well. So we obviously are able to monitor to a certain extent. We also work closely with the Care Quality Commission, who have got powers to go and inspect and send, large teams of people in with specialist knowledge as well into clinical areas, which is what they've done in maternity, the emergency department and surgery as well. And also NHS England Improvement, who they basically have the powers to sort of rate trusts and mandate support for trusts as well in that regulatory sense. On the emergency department, we were working very closely on those particular issues with the Trust and continue to do so. And we already had done a lot of work there with them. On maternity, we had raised a number of issues and with the Trust, and we're working alongside them and are doing that now with the sort of full picture as well from the CQC inspection in addition to that. And we are now jointly overseeing the improvement along with regulatory colleagues as well. So I think that's between the three parties in terms of that monitoring, it gives us a very robust approach. The culture, I'd say that's difficult sometimes from outside to get that full picture, but we are now actively very much supporting around the governance management of incidents and some of those areas as well. So I think, as Rosa said, we were aware of some of the issues. We have been able to work and continue to work with with the regulators so that we can, between us all kind of do our contributions to making sure that the services are as good as they possibly can be, along with the Trust, of course. Thank you.
Okay, thanks, Rosa and Amanda, for that response. So the next question is a finance question, Stuart, and it goes as follows. It says 4.6 of the expenditure on your slide was listed as other. Could this be defined?
It can. So the breakdown of other, I mean, these are sort of national classifications that we have to group things together, and probably the biggest area, particularly around that, is the NHS contribution to the Better Care Fund, which is a fund nationally between health and social care, and that's 35 million of the 84 million. We've also got other areas which don't just naturally fit into those categories above. So we've got patient transport, we've got 111 service, we've got a series of estates costs, and then we've also got a collection really of smaller contracts that don't naturally fit under community or acute. So there'll be a whole range of small providers that help to make up that relatively small but still quite material in terms of money in that category. Thanks.
Okay, thanks, Stuart. The next question reads as follows. What plans are in place to improve dementia care in the community? Stephen and James, I don't know whether you want to comment about it from a primary care perspective first, and then Amanda, perhaps you want to come in with a commissioning view.
Thanks, John. I can start. So there currently are transformation plans looking at dementia care in the community, and we're particularly looking at trying to improve the speed to which we can get diagnosis done, and looking at to improve the speed that we can get people to have the tests, the head scans, to allow all those processes to happen. So that is actively happening at the moment, but there is a clinical team working on transforming the pathway to see to improve it in the best ways we can.
I guess there is a good example, isn't there, James, which is that we identified probably 12 months ago now that the waiting times for initial memory assessment clinics were very long in Nottinghamshire compared to some other parts of the county. And we did act as rapidly as we could to put some extra funding into that area. And the good news is 12 months later, the waiting lists are very short for that. So that there has been work done on some aspects of dementia in the last 12 months. Amanda, did you want to add anything to that?
No, thank you, John. I was going to say what you've just said. Thank you.
Okay, great. So I'll keep going then. The next question is, will the work with care homes be across the whole network and include private homes as well as council-led homes? From personal experience, private care homes would benefit from the training discussed just as much as others. Stephen, please.
Yeah, the simple answer is yes, it will, and so it should. Our responsibility is to the resident before the considering the kind of organisational form or structure in which that patient is living. So the care home model actually is something which is worthy of highlighting. It's a model which originated in Nottingham City, spread into Rushcliffe and beyond. It's a model which has been profiled nationally. It's a very, very high quality model of advanced care planning, care coordination, in reach from regular scheduled visits from GP practice and community nurses, support from dietitians. It's a genuinely good news and a service which we're very proud of. One of the dimensions of the service which is relevant to the question is actually that the engagement of the care home staff has been really, really positive. They have historically been dare I say, a Cinderella service, out of sight and possibly out of mind. They are nevertheless now part of the care team, explicitly part of the care team. They're the care home managers' support to giving their staff training and allowing their staff to receive training has been tremendous. And there's a genuine sense of partnership between the statutory services, GP services, and the care home management, which is developed in the last 2 or 3 years. So a very positive story on care homes, I believe. Again, particularly important because they are a class of patients to whom we owe a special duty of care, I think.
Okay, thank you, Stephen. I'm just going to say that Christine's typed, not a question, but has typed, thank you for everything you are doing. So Christine, I just want to say thank you. We're all very appreciative of that type of feedback. So thank you for saying that. The next question is around the work of our Patient Public Engagement Committee and reads, as only 50% of the responses to the childhood mental health issue were from patients or parents, what is being done by the PPEC to improve information from this sector? Is too much reliance placed on online surveys when many do not have access or willingness to participate in these? Sue, please.
Thank you. Yes, I think the engagement team are trying very hard to talk in a meaningful way to the cohorts of patients and residents in a way that's relevant to them. This piece of engagement was actually done in a period where it was quite difficult to do any face-to-face engagement. And I think the fact that the engagement team used a specialist service in terms of talking to young people was a step forward in terms of the type of engagement that's been done. And of those responses, a number came from a quantitative sense, an online survey, but in a more meaningful way, this was supplemented with focus groups, with peer groups, talking to peer groups about these issues. So I take the point that online surveys are not ideal, but there was a plethora of different media used to try and reach and target specific cohorts of people, and young people do like digital conversations. So I think the engagement team try very hard to apply the right techniques to the right people, but as we can open up more, obviously face-to-face engagement is very important, but only if that's what that audience, how that audience wants to talk. So I think this was a new way of talking to young people, which I think produced some very, very good caliber feedback. And it's the mixture of both quantitative and qualitative work. And that's what the engagement team is doing. And that was also raised at the PPEC to challenge back to the engagement team. So thank you.
Thanks, Sue. So we have a follow-up question around dementia. So I'm just going to take that one next. And it says, my question related to the lack of care after diagnosis. If this was improved, e.g. Admiral nurses, the impact on hospital admission for this group of patients might be improved. Amanda, can I come to you first, please?
Sorry, I just couldn't get my off mute. Yes, I think I agree. I do think, I mean, the speed of diagnosis is with a view to being able to wrap support around more quickly rather than people kind of being left in limbo. I do think there is further work to do, and we'll do that with place teams to think about how all of those different bits of the community do work together. We are in the process of doing some looking at how all the community services work together, and certainly dementia will be a sort of it's one key area where it's a growing area, and it's things that we'll need to do. So there is still work around that we will need to continue to do. It's a very good question. Thank you.
Thanks, Amanda. So moving on, the next one is, how do you see, I think I'm probably coming to you again, Amanda, how do you see locality teams after April next year? If they are not part of the new ICS, where do they go? And what might the employment model be? So I think you probably just need to explain a bit of context around that, please, Amanda, as the lead in.
Yes, thank you. So in the new Integrated Care Board, which will be the NHS body, there will be elements which are done in the as one across the whole population, and that will include Bassett Law as well as the current CCG area. And then there will be 4 places within that. So there'll be Bassett Law, South Nottinghamshire, city, mid-Nottinghamshire. The people who work for the CCG currently will automatically transfer into the Integrated Care Board. So as their employment will automatically transfer to the new body. So it still will be very much part of the system, just working in one locality rather than across the whole area. And all of the roles are equally important and complementary to each other. And the intention is that we work kind of as a family. So some things will be done once where that makes sense to do that at a bigger population scale, where it's more dependent on local relationships and is more community facing in terms of the services and more population specific as well. Then those teams will continue to work in those areas. So still very much part of the ICS and working in the localities just as they are now really, and will continue to be employed by the Integrated Care Board. Thank you.
Thanks, Amanda. And the next one is the addition of social prescribers is a welcome addition to the practice team, but their referrals to volunteer groups is putting strain on these groups who by definition are volunteers. How can the CCG help? I'm going to come to one of the GPs, I think, please.
If I may, then I'll start. And thank you, Peter. Yeah, this is clearly a success story with unintended consequences. The recruitment of voluntary services and voluntary groups to support patients' care needs in the community has been unequivocally a good thing, and manifest benefits have accrued in a very short period of time. And yet it has quickly, well, if I read your question correctly, it's quickly challenged capacity, and clearly that what can the CCG do about this? Well, the CCG needs to alert the place-based partnerships, the ICP and the PCNs to this, and to encourage the conversations which take place between the PCNs, the place-based partnerships and the voluntary groups, to ensure that there's appropriate referrals to an appropriate service with appropriate capacity. One thing I would say actually is this does create the dynamic for changing the way we spend the money. If the service is manifestly good and producing good outcomes for the citizen, for the patient, for the professionals, the providers, and for the system, as I believe it will do and is already starting to do, then it does create the powerful incentive to divert some of the money we currently spend in other parts of the system to these types of activities. And I would think that the opportunity which exists through the ICP and the primary care networks to recognise that and to make preferential investment locally in such services is a huge opportunity afforded to us by becoming an ICS.
Okay, thanks, Stephen. Does anybody want to add anything? If so, please speak up. If not, I'll keep going. Okay, so thanks, Stephen. I think the next question is an interesting question. I'm probably going to come to Rosa to see what you know, Rosa, and it is asking or saying that GPs really benefit from patient participation groups. Would it be possible for care homes to have PPGs? Do you have any knowledge, Rosa? I mean, obviously they're private organisations, and I guess it's not part of the contractual arrangements today that it's mandated for them to do so. And I guess it's variable, perhaps. But go on, over to you.
So absolutely, and I think you've hit the nail on the head, John. There are some homes that have really great engagement with families and carers of their residents, and there are others that don't. I think there is something perhaps we could think about doing through our joint care homes and home care work about how we have some of that lived experience captured in that work. So we do that to a limited extent already, where through some of the personalised care work, one or two people may be involved in our My Life Choices group, for example, where they share that real lived experience, and that helps shape our involvement with care homes. So I think that's a great idea to take away, think through a bit more for those homes that don't do that as well, and see how we could perhaps do something on a slightly broader level. I don't know who's put that question in, so apologies, I can't get in touch with you directly, but my email address is on the CCG website, and if you wanted to get in touch with me to discuss that particular thing further, I'd be more than happy to do that.
So the question's from Teresa, Rosa. So Teresa, we have your details, and we'll make sure Rosa picks up with you offline. But I think Stephen and Sue both want to add something. Stephen, you go first.
Yeah, I think it's a really tremendous question, and I mean, there are obvious ways of getting around this. And patients with frailty and those with cognitive issues, notwithstanding, they could have representation from another resident, or indeed a member of the PPG could be deputed to represent the care home's interests in the PPG. They could be linked by video technology to the PPG meeting. Most of our meetings currently are virtual, so that's certainly possible. Or indeed, I know that some, again, going back to Peter's observation around the voluntary sector and not wishing to burden that sector with extra work, but in the original Rushcliffe work around this, we had age concern worry catchers, people, volunteers from age concern, who would go into the care home and talk with their residents and ask them to gather their kind of concerns, their ideas, and act in an advocacy role between them and the care team led by the GPs and the community matrons. So it's a really good question. It's a challenge to us to make sure that we find a means to achieving this, as it does other interest groups, for example, like young people.
Okay, thanks, Stephen. Sue.
Yeah, thanks to Teresa, who raised this very point yesterday at our PPEC meeting, day before yesterday. It will be picked up via that route, so it will go into discussion at the governing body. So it's a very, very good idea, and I think we'll work on it. So thank you.
Okay, great. Thanks to you. Thanks for the question, Teresa, and we'll pursue it after the meeting. The next question, I think we may have to seek some more information after the event, but the question is, there is excellent research being carried out at NUH, but no available budget to spread the results, thus improving care to relevant staff. So Amanda, I guess we probably need a bit more information, don't we, that we haven't got today. How would you like to handle it? Would you like to pick up with Margaret, who's asked the question separately?
I'm very happy to do that. Yes, I think what we do, the way that we work currently, is that where research is undertaken, sometimes the CCG will contribute to the treatment costs that are brought about through the research that are not kind of routine care. They're things that are being trialled. They're not proven at that point. And then when we do have research findings, we do, as part of our sort of planning, look at putting that in with all the other kind of proposals for developing services, and then we have to prioritise which ones get taken forward. And so sometimes research findings are put into practice, but sometimes, as the question suggests, there isn't any additional available funding, and it's not one of the sort of key priorities that we take forward. So that's a general response, John, but I'm very happy to pick up any more specifics outside of here. Thank you.
Okay, so Margaret, we'll capture that and we'll get in touch afterwards to understand what the specifics are, and then respond as best we can after that. So I think we've got just one more question at the moment, which is, are there any plans for training to support newly formed voluntary groups to play their roles with patients, carers who live with long-term conditions? Have you had discussions around that in your PPEC forums, Sue?
We haven't specifically, but thank you to Gilly for raising it. I think it's something that we need to consider, and I don't quite know what the answer is, but I think we'll bring it up at not just engagement, but I think it's about package that we might be able to get put in place to support those volunteers, because it's a hard job that they do.
Okay, and sorry, Sue, is Gilly known to you? Are you able to have yes? I'm sensing
yes. I can absolutely follow that up with Gilly. Gilly's a key member of the PPEC, so thanks for raising it, Gilly.
Okay, great. So we'll pursue that one afterwards as well. So I think
John,
that
just
concludes.
sorry,
Sorry, Amanda.
Yes, just to add is that in terms of how we work going forward, we are currently meeting with the voluntary and community sector sort of umbrella organisations. There's a number of them across the patch, just to sort of test how we can link in and develop those relationships, because there are some organisations around who do help to develop new groups. So it's just how we make sure that that is understood across networks and that people can tap into it and it's supported as and when it's required. Thank you.
Okay, thanks, Amanda. That's really helpful. So thanks everyone for the questions. I think there's some really important questions there, and I trust we've answered them professionally. And of course, we will follow up where appropriate, those where it would be helpful just to have a longer dialogue after the event. So we will do that. I hope people have found the presentations this evening informative and useful. So that does now bring our annual public meeting to a close. So I'd just like to finish by thanking everyone again for taking the time to join us today, and to wish you all an enjoyable remainder of your evening. Thank you, everybody.